Hello and welcome, everyone. My name is Kristen Talbot. I'm the program manager for MAVEN Project. Thank you all for joining us today and our friends at Yakima Neighborhood Health Services for hosting today's session, Tuberculosis, Diagnosis and Treatment with Dr. Saadia Griffith-Howard. Dr. Griffith-Howard held multiple clinical and administrative positions until her recent retirement from formal clinic practice. As an infectious disease physician, she has over 30 years of experience providing direct patient care in the ambulatory and inpatient setting. She's participated in infection control and pharmacy and therapeutic committees, as well as emergency and disaster management planning related to organizational responses to anthrax and COVID-19. And we are just so very lucky to have her as one of our MAVEN Project volunteers. So, Dr. Griffith-Howard, when you're ready, please begin.
Okay, good morning. It's lunchtime where I am. I'm on the East Coast, but I know it's early for you guys. Thanks for joining and for listening to this talk about tuberculosis. I have nothing to disclose, so we can work through that. And Christian already told you about the accreditation activities here, so I'll go straight to our objectives. I will recognize that my title of my talk, Update TB, is a little bit different than what's been billed, but I think we're going to cover the same issues, and especially in terms of treatment, it will be mainly on TB infection because I think that's what you run into mostly in your clinics. I would like to thank Dr. Miriam Cameron, who shared some of her slides with me, and they were the nicest for this presentation. And I always like to say before I start that you're going to see several graphics in here, and I always just grab my graphics from the CDC or the World Health Organization. So if there's something that you like, you can certainly go to those as resources if you want to put up any signage in your clinics. So what are we going to do today? Hopefully by the end of this presentation, I will have reviewed statistics on the burden of Mycobacterium tuberculosis disease globally and in the United States. You'll recognize the updated nomenclature for MTB infection and disease. You will have compared the two modes of testing for MTB infection, so you'll understand when you should do an IGRA and when you should do a MAN2 test. And we're going to review the treatment options for MTB infection. And I'm going to spend the last few minutes really talking about your local health department. I actually reached out and was able to have a conversation with your TB control personnel, and they were very engaging and enthusiastic. So I think that'll be a great resource for you. So let's get started. So of course we have to get started with some statistics. This graphic is from World TB Day 2024. So as this is implying, and as you already know, tuberculosis continues to be a worldwide problem. So worldwide, TB is the second leading infectious killer after COVID-19. So it at this point is above HIV and AIDS deaths in worldwide, or in terms of killer worldwide. In 2022, and one of the other themes is that our TB data, of course, lags by the time we collect it. But in 2022, an estimated 10.6 million people fell ill with tuberculosis worldwide. That includes 5.8 million men, 3.5 million women, and 1.3 million children. And it's felt that a total of 1.3 million people died from TB totally in 2022. And that includes 167,000 people with HIV. So again, as I said, it is a big issue worldwide and continues to be. Countries with high TB incidence, and this is usually characterized as greater than 100 cases per 100,000 in your population, include most of the countries in Africa and Asia, many of the countries in Eastern Europe, Central America and South America, as well as Haiti and the Dominican Republic. And when we look at the people with tuberculosis around the world, most of it, about half of it, can be found from 8 countries. And these are Bangladesh, China, India. You see the other ones listed there. And China and India especially are our sources of over 50% of our drug-resistant TB that we face worldwide. So in March of this year in MMWR, the CDC updated the TB numbers, and these are the numbers as of 2023. So that's the most recent information we have. Again, as expected, they're at a lag. So you will see that 13 million, up to 13 million people are estimated to be living with latent TB infection in the United States. And in a few slides, we'll talk about the new terminology, but that's the one that we all know. And so in 2022, there were 8,331 reported TB cases in the US, and that actually increased to 9,615 in 2023. So that is a case rate of 2.9 cases per 100,000 population here in the United States. And we experienced the last year, they had information about deaths, 602 deaths in 2021. And just, I'll say this several times, but I'll go ahead and say it now. Again, 30% of people who are exposed to tuberculosis develop TB infection. So not everybody exposed will develop TB infection. And then of those, 5 to 10% who have exposure and develop TB infection will go on to have active or later in life reactive TB. And most of the tuberculosis in the United States, 80% of it is reactivation tuberculosis. So looking again a little bit more in our states, and you'll see here, again, I took a graphic from the CDC, but 40 states and Washington, D.C. reported an increase in TB cases and rates in the United States. The good news for you in Washington state there is that you actually had a decrease in your tuberculosis cases. In 2022, there were 251 cases, and in 2023, you were down to 222 cases. So in Washington state, you experienced a 12% decrease in TB disease, and your rate overall was 2.8%. So very close to the median in the United States, but still something you need to be thinking about. Cases of TB disease increase among nearly all demographic groups, but like we learned for COVID-19 and other infections, there are disparities, and certain groups, as expected, do experience higher rate of TB disease. And again, as before the pandemic, TB rates in 2023 were highest among non-United States born patients or people. And again, here's the slide that sort of shows it. And again, this is now from 222, so it's not the latest information. But again, you can see Washington State with your incidence rate. Again, as I said, most recently it's 2.8%, and your cases are around 222 in 2023. So let's do a little bit of talking about the nomenclature. And, it's hard to teach. I won't call myself an old dog, but we have to learn how to refer to things appropriately. So when I was in training, and I'm sure when many of you were in training, we talked about latent tuberculosis, but our nomenclature has been updated, and we now, instead of latent tuberculosis, should be using the terminology tuberculosis infection, and usually you will see it abbreviated as TBI. And this is us trying to recognize the idea that in TBI, or tuberculosis infection, actually you have been infected with the tuberculosis bacteria. You usually are asymptomatic and non-infectious, but during your life, you can have viable organisms during the years that your immune system is trying and hopefully successfully containing the infection. So that is the rationale for why we treat people with TBI, tuberculosis infection, with medications to decrease the viability or to kill any organisms that they still may be retaining in their system that are viable. And then instead of using the term of active tuberculosis, we now use the term tuberculosis disease, or TBD. And this is when we have identified the Mycobacterium tuberculosis bacteria from either a bodily secretion, from bodily fluids, or from tissues if we make a tissue diagnosis. But it's important to remember that we always have to have a high suspicion for tuberculosis disease in certain populations. And in approximately 5 to 20% of TBD cases, they are presumed because of a clinical diagnosis based on risks, physical exams, TB testing, and labs. And we are unable to document the actual presence of the TB bacteria. So sometimes there are cases that get treated without actually having bacterial growth. So I'm going to try in this presentation to use TB infection and TB disease, but I know I'm going to lapse back into the old nomenclature, so forgive me if I do. So let's move on and talk about who should we test and who should test in preference to treating for TBI, so for TB infection. And I recognize that many people who present to you for TB testing are for required TB testing for school, for jobs, those kinds of things. But one of the principles that we should always keep in mind is test who you would treat. So that if you have the opportunity to make a decision on whether to perform a TB test in your patient, you should say, if this test is positive, am I going to treat it? And so thinking back to some of the questions that we run into sometimes, at least that I have run into in MAVEN, is I might have someone who's very low risk, but they're over the age of 65. For some reason, the provider decided to do a TB test on them, and now the TB test has come back as positive, and then they're concerned, which is appropriate, should I put this person who has no symptoms of active TB, who's really at low risk for progression, do I need to put this person over the age of 65 and sometimes much more elderly on TB medication? So again, just encouraging you to sort of think and not to just do a reflex, oh, I'm meeting you for the first time, I'm going to do a TB test on you. You should put some thought into it. So again, let's delve into this a little bit more. So again, who should I treat? So you need to ask yourself, are they at risk for a new infection? So in the United States, who are our patients who are at risk for new infections? So of course, and obviously, if they're a close or casual contact of someone that we know has untreated tuberculosis disease, which we used to call active TB, those are people who we want to test. And the CDC classifies if you have over 4 hours per week of contact with a person, you're considered to be a close contact of the TB patient. If you have under 4 hours, you're still considered to be a casual contact. So basically, if you've had somebody who has contact with somebody with TB disease, they should be tested. IV drug users, residents or employees of homeless shelters or correctional facilities. Again, that makes sense. Small areas, maybe not the best air filtration and time spent together, and certain healthcare workers, but certainly not all. But again, a lot of times the testing for healthcare workers is mandated by their organization. The second question you want to sort of put in your mind is, are they at risk for reactivation? So I want to test people who are at risk for reactivation. People at high risk for reactivation, if they've been exposed to tuberculosis, you see all of your HIV infection, chemotherapy, various kinds of immunocompromising cancers that I've listed here. Treatment with a TNF antagonist would put them at high risk for infection, renal failure on dialysis, and people with abnormal chest x-rays or silicosis. You see that diabetes and use of glucocorticoids at least a level of 15 milligrams per day for a month or longer are considered to be moderate risk. And low risk are people who have an abnormal chest x-ray with 1 granuloma, and people from high prevalence countries who don't have other risk factors above. So again, you're still going to think about testing people from high prevalence countries, but if you have elderly people and other people who really are low risk and you're not concerned that they have a new infection, again, you should think about whether you're going to go ahead and perform a TB test on them. All right, so let's talk about what TB tests are available. And we do have 2 TB tests available for us to use. We have our interferon gamma release testing, and we have our old-fashioned or our tried and true tuberculosis skin test, TST, also known as the MAN2 test. And the CDC has come out to say that the IGRA tests are preferred, but certainly either test can be done. And depending on your clinic limitations, your lab limitations, you can decide, and also depending on your patient, you can decide which is the one that you would prefer to perform. So just taking a second to look at some of the issues with both tests. So with the MAN2 test or the PPD or the TB skin test, TST, any of those 3 names are appropriate. The big thing that we always worry about is you'll place the test. Are they actually going to come back for test interpretation? Certainly, there are placement and reading areas. We really want to we want to measure the indurated areas of the test, and there's different levels of induration, which we'll talk about on the next slide. So there are staffing concerns, there are training concerns, there can be false negatives and false positives. You have the booster effect, and a lot of times, depending on your population, it can be hard to convince somebody who has received BCG as a child that their TB skin test is really indicative of a TB tuberculosis infection and not just a result of their BCG receipt. In terms of our IGRAs, they don't cross-react with BCG and in general other non-tuberculosis bacterium. So that's really a nice check in their column. It does not cause the booster phenomenon that we can see with the TB skin test. So that's why you don't have to do the double test. Depending on where you are in your lab, you can have results available in 24 hours, which can have implications for isolation of patients, etc. However, there is cost associated with this. There are lab processing concerns, which can lead to false positives and negatives, and there are accuracy concerns. So neither test is perfect. And so again, that gives you a chance to make some decisions. So again, the MAN2 test, which we also know as the PPD and the TST or the TB skin test, again, they're going to come back for reading. You're going to have your nursing staff who hopefully are trained in appropriate placement, and they come back in 48 to 72 hours later for their interpretation. And you're going to measure that induration in millimeters, and you're not going to measure erythema. Erythema doesn't count. And you have different levels to be accepted as a positive test associated with different sensitivity and specificity. So again, I always have to look at these 5 minutes before I go back and interpret my tests if they're not negative. But again, 10 millimeters is positive for recent immigrants from our high-risk countries that we talked about previously, if they've come within 5 years, and again, within 5 years. So again, someone who's been here for 15, 20, 25 years, and you discover they're positive TB test does not necessarily take you down the treatment guidelines, depending on how old they are. And then you have those who are 15 millimeters or greater is positive for any person. And then for those people who may be immunocompromised, such as with HIV, and also those who have recent contact with active TB cases, an induration level of 5 millimeters or greater is considered to be positive. So again, that can vary. And I think we're most comfortable with this because that's the test that had been around for such a long time, and most of us in our training had that. So our newer tests are interferon gamma release assays. And we have two. We have our quantiferon goals, and we have our T-spot test. And you can see their sensitivity and specificity is outlined here. And actually there's a quantiferon gold plus is the updated test that's available here in the United States. Now, these tests are really tests of cell-mediated response to antigens of Mycobacterium tuberculosis. And they look for the release of interferon following stimulation by these antigens. And these antigens are unique, that they are used are unique to Mycobacterium TB, although a few other mycobacteria may rarely react with this test. So again, you have to have viable cells for this test to be successful. So that means you need to make sure that your test is collected, or your blood sample is collected correctly, is stored correctly, is transferred to the lab correctly, so that you have the opportunity to get an appropriate, a positive or a false, positive or negative test for your interferon gamma release assay. So again, there are still issues with that. Limited data for the accuracy of these tests in patients less than 5 years old. I always give the caveat that I'm an adult infectious disease doctor, so I don't necessarily talk that much about children. But more recent data suggests that they are probably accurate down to a level of less than 2 years old. So if they're 2 years old and older, the test can be interpreted. Less than 2 years of age at this point, there's less data and concerns about accuracy. There's a slight preference if your patient has received BCG, because if the patient has received BCG, they should not have a positive test on these IGRA. So that makes those kind of conversations a little bit easier. And when you get your results, laboratories can give you both the qualitative and quantitative results. And basically, for our purposes as clinicians, we're looking at the qualitative results of this test. And one of the things that we are often questioned about is if somebody has their quantiferon plus or their T-spot and their test results are not truly positive or negative, and they come out with an indeterminate, a borderline, or an invalid result. And I think that people have a tendency to try to interpret this as, especially if it's borderline, oh, this is going to be positive, they're on their way to a positive TB test. And that is not true. You should just look at this as uninterpretable. So if you get an indeterminate, a borderline, or a valid result, you should just say that's an uninterpretable result. It does not mean that this patient is on their way to having a positive TB IGRA test that I need to, pursue at this point. So what do you do when you get those kind of results? Well, the first thing you want to do is, of course, repeat the test. If you have somebody who's suffering from an acute infection, they got the flu or something like that, you want to wait until that's over. But in general, you just go ahead and repeat the test. If possible, you can switch to the other test. So if this person was a quantiferon plus test and you have the ability to do a T-spot, you can switch to the T-spot at that point. But if not, you just want to repeat the test. And then if you get into a situation where you have repeated tests that are staying the same, so every time I do the quantiferon plus, it's indeterminate, I've done it twice, then that is somebody who you can revert to the TB skin test or the MAN2 test to try to get your results. If you ever get a positive, let's say the person on the quantiferon test, first it was indeterminate, then it's positive, you accept that positive test. Similarly with the T-spot, it was borderline and now it's positive, then you consider them a positive test. If it's the second test is negative because the test worked that time and you get a negative result, you also would interpret those as negative tests. The the quantitative results, which can be reported as numerical values, are mainly helpful if you have somebody who has repeated indeterminate or borderline tests, and you need some additional help in interpreting the test. But that would not be something that we would do by ourselves. We would do that in combination with a discussion with our lab partners. So again, the IGRA tests are what's recommended preferentially by the CDC. They are very good. If you get a positive or a negative, you can interpret those and go forward. If you get those indeterminate, borderline, or invalid results, the first step is to repeat the test. If you have the ability to go to the other test, you can do that. And hopefully on your second test, you will get a reading that you can interpret. So now getting to things that we already know about. So TB disease, signs and symptoms. Again, so these are people we would previously have called active TB, but now we're calling them TB disease. And we all know this. Our symptoms can be persistent cough, fever, weight loss, night sweats, lymphadenopathy, hemoptysis. And when we have TB that's extrapulmonary, you can have blood in your urine, hematuria, you can have abdominal pain if you're having other issues. So again, our most common active forms of TB are pulmonary TB, and that's what we're most concerned about because that is the most easily infectious form of tuberculosis. And our lymphatic disease with scrofula, especially involvement of our cervical lymph nodes being the most common forms. Pott's disease, involvement of the vertebral column or the bones, genital urinary disease, or disseminated miliary TB are less likely, but they do occur. And we have to be especially concerned about disseminated disease with our immunosuppressed, especially our HIV positive patients. So our chest x-ray, we definitely look for signs of upper lobe infiltrates, and that can be cavitary, miliary pattern, or granulomas. So we can see any of those with our chest x-ray signs. And other findings, if we have extrapulmonary infection, can be in the genitourinary system, ascites, pleural, or pericardial effusions. So you can have other findings with our TB signs and symptoms. So again, I guess one of the take homes from this slide would be that it can be different presentations. We're all on the lookout for our most common pulmonary presentations, but in the right situations, when we have symptoms and we have evidence for illness in other places, we definitely need to keep tuberculosis disease in our differential diagnosis. Now, one of the things I wanted to stop here and just remind us all of is our infection control principles, okay? And I think that we all get sort of lulled into the situation that, oh, they have a positive IGRA, a positive PPD, and by knee jerk, we just send them on to having chest x-rays, et cetera. But again, this is a time for you to stop and think. You probably have screened your patient perhaps for TB symptoms, TB disease symptoms at the time you placed the test or ordered the IGRA testing. But if somebody has a positive test, you should rescreen them. Do they have symptoms that can be consistent with TB disease, especially pulmonary TB disease? And you definitely want to do this before sending that patient for their chest x-ray or any other studies or appointments. And, in my infection control days, we always have the person who's been walking all over the clinic for the last 3 days as they're going on their journey of diagnosis. And we have a lot more people exposed than we need it to be. Any patient who has symptoms of TB disease should be in airborne isolation, and they should wear a surgical mask outside of isolation. Certainly, if you don't have an isolation room, you still want to keep them, in a closed door room, behind a closed door in your clinic. And you want to refer them urgently to the Department of Health and advise the patient not to go out in public. And I had one case where we told the patient, well, you shouldn't go out, but they didn't understand that they shouldn't also go to work. So even though they were being very good about not going to the grocery store, they were still going to work the whole time when we were doing their diagnostic workup. So again, I have the patient go into isolation. You don't want people who they have not been exposed to. Um, being exposed to them while you're doing your workup. So again, just bring your diagnostic tools whenever you can to them. In my clinic, if we had somebody, we would make sure that the X-ray department was ready for them. We walked them down, they wore their mask. The X-ray people had on their N95 respirators. We did their chest X-ray and we brought them back to the room as soon as possible, and then we waited for results. So those are the kind of things you certainly want to continue to do. Okay, so let's talk a little bit about our treatment for TB infection. Okay, so now we've screened our patient. We know that they do not have any evidence of TB disease. We've done our chest X-ray. We don't see evidence for pulmonary TB, and if it's appropriate, we have also done the additional testing for extra pulmonary TB. So again, it's very important. What you don't want to do is do one drug therapy. So if it takes a moment for you to make sure that the person doesn't have TB disease, it's very important for you to go ahead and do that. In general, no regimen is superior to others. And so a lot of the choice of which regimen you're going to choose to treat your patient with is going to depend on who your patient is, how they're going to do over the months of taking the medication, what other comorbidities they have, in helping you to decide which regimen you're going to use for your patient. We always are concerned about underlying liver disease when we are treating patients for TB infection. And so especially you're going to be looking for patients who may have alcohol use, patients who may have chronic hepatitis, your patients who are using drugs actively, injecting drugs actively, those who are potentially on hepatotoxic medications, and patients who may have underlying problems with already elevated liver function tests. And remember, especially when we talk about our rifamycin-based regimens, there are so many drug reactions and interactions that can happen with those medications. You definitely always want to use your tools that you have to check for drug interactions. You want to assess your patients for neuropathy. Again, are they at risk for neuropathy? Do they already have neuropathy? Because we know our isoniazid based regimens can cause that. And as I said before, you want to review your drug-to-drug interactions. So these are the things that you're going to be, looking at before you make a decision on which regimen you want to use for your patients. And again, I'm referring to our non-pregnant adults without HIV infection at this time. So we have basically 3 regimens that we can look at for these patients that are rifampin based. And then of course we can talk about our isoniazid on the next slide. So as I said, you're going to always worry about drug interactions with rifampin. We know that we feel that rifampin is safer because it doesn't have the known hepatotoxicity that we know about with isoniazid, but hepatotoxicity can occur with rifampin, so the risk is not zero. So again, even though you're maybe less concerned with your patients who have abnormal LFTs, you still want to watch it for that. In addition, we have the issue more recently with nitrosamine levels contaminating our rifampin drugs, and nitrosamine has been shown in some long-term studies, especially of animals, not really of people, to possibly be an increased risk for cancer. It's unclear if there is any increased risk for the 3 or 4 months that rifampin might be used as a TB infection treatment, but that is something that you would have to share with your patients, the FDA has increased the acceptable level for nitrosamine because of the concerns. But again, it is still a discussion that you might want to have with your patients. And that may lean you a little bit more towards using an isoniazid alone based regimen. But we have our 3 regimens here. We have rifampin daily for 4 months, and people tend to like to use this one mainly because it's such a short duration and people can mainly stay with that as opposed to 6 months or longer if you're going to do isoniazid by itself. You have isoniazid and rifampin daily for 3 months, and then you have the isoniazid and rifapentine weekly for 3 months. And the advantage of that particular regimen is it does lend itself to direct observed therapy, and that's one thing that we do know. We want to make sure that our patients take our medicines that we give, and for certain subsets of patient, the DOT, even for TB infection, is something that we would try to do, and DOT meaning direct observed therapy. We do not want to use rifampin and PZA together due to risks of severe hepatotoxicity, and previous regimens had used this or recommended this, but it is no longer recommended. So again, if we have a concern for drug-resistant TB, that is a different discussion. But in the patients that we expect this to be positive, it would be choosing one of these 3 regimens for us to do. I'll talk a little bit about monitoring in a second. Okay, so for certain patients, we still may want to use isoniazid-based regimens. And again, the main issue with isoniazid are 2. Certainly, we're all familiar with hepatotoxicity. Hepatotoxicity incidence is basically less than 1 to 1,000 if we are 20 years of age, and it increases with age, and it actually maximizes out in the 50 to 64 age range as 23 cases of hepatotoxicity per 1,000 patients treated, and that drops to only 8 per 1,000 for those over 65 years of age. But the bottom line is, as patients get older, the risk of isoniazid toxicity increases, and so that is something that we have to factor in our treatment choices. And the traditional 9 months, of course, is a long time to be adherent, to a daily medicine, and there are concerns that patients will not do that. And 6 months regimens have been shown to be effective, and so many treaters try to get the patients to 9 months, but if they get to 6 months, we can feel comfortable that they have completed enough therapy for their TBI infection. Of course, because of the neuropathy concerns with isoniazid, we do always want to use it with pyridoxine 50 milligrams once daily with their isoniazid is the way that we would go with treatment. And there is a twice weekly dosage for isoniazid for 9 months if that is something that you would try to use with your patients. But again, because of the increased amount of time, there's always concern about adherence. So what do we need to do in terms of monitoring when we have our patients on TBI or TB infection treatment, formerly latent TB? So the formal recommendations are that patients are seen monthly on TBI therapy. And I would say that in some of the things that I reviewed, and the recognition now of virtual appointments and those kinds of things. Many people will say that the patient needs to be contacted monthly when they're on TBI therapy. So again, this is not somebody you just put on therapy and you say, I'll see you in 6 months, I'll see you in 9 months. You do definitely, or in 4 months, you definitely want to be seeing or contacting them on a monthly basis. They don't necessarily need to have labs on a monthly basis, but certainly for patients at high risk for liver disease, our older patients, our patients that may have started out with some abnormal LFTs, et cetera, especially our patients on isoniazid, you want to consider doing your liver function testing. And then, of course, you're going to see here if their transaminase levels become greater than 3 times the upper limit of normal, if they're symptomatic with symptoms of hepatitis, anorexia, jaundice, etc., or if they're asymptomatic with their levels more than 5 times the upper limit of normal, you certainly want to discontinue your isoniazid, especially, and also remember rifampin can also cause hepatitis. You would stop your medications and watch them. Now, in blue here, I have educate your patient on the symptoms of hepatitis and instruct them to stop the medication and to seek prompt evaluation of symptoms. And I think that actually is the most important part of it, is that first of all, you want to document that you educated them on the symptoms of hepatitis. But someone could have labs on Monday, and then on Friday they can start to develop evidence of hepatitis. So you really want your patient to be empowered to understand what they're going to be looking for. And if they develop any of those symptoms, the appropriate thing would be to stop and to call you. Most hepatitis is going to occur within the first 3 months of therapy, especially with isoniazid. So once you get past that time frame, you're usually in the clear, but you still want your patients to be vigilant, and if they develop symptoms, to let you know. I also tell my patients not to drink alcohol while they're on isoniazid, especially, but also sometimes with rifampin, so that you're less likely to have inflammation of their liver. And of course, with rifampin, you can have, or rifamycins in general, excuse me, you can have a rash, unexplained bruising, you can have thrombocytopenia and heme problems. So if they develop any of that, and you can also have hypersensitivity reactions, again with fever, etc., you want to tell them to stop their medication. So bottom line is, most people who have TBI infection are feeling well, they don't have any symptoms. And if they start to feel anything abnormal, that should be something that we should analyze and see what's going on with the patient. So now you have your patient with TBI, and before you have done anything, you get a positive screen. What are your next steps? So again, uh, don't rush to put people on treatment for TBI until in your mind you are absolutely clear that they do not have TB disease. So that's one thing just to reinforce. We know that with abnormal chest x-ray, it's pretty clear, but if somebody doesn't have an abnormal chest x-ray or pulmonary symptoms, you do have time to make your diagnosis of disseminated or extrapulmonary TB. So let's say somebody does have an abnormal chest x-ray or pulmonary symptoms. What are your next steps? And your next steps are obtain your sputum for AFB smear and culture. But also we have testing now for nucleic acid amplification testing, or NAT testing, which will allow you much quicker to find out if you're dealing with Mycobacterium tuberculosis disease versus a non-TB mycobacteria. And you're going to collect 3 sputum specimens 8 hours apart, and at least one should be an early AM specimen. So those are the tests you should do. And again, your Department of Health will help with the diagnosis of some of your patients, but not all. So again, they are available for advice, but you should know what the next steps are. And if you have concern for extrapulmonary TB, of course, the appropriate scans, and usually those will come to a biopsy situation, is what is needed. And again, it's if they're non-infectious, they don't have pulmonary TB, it's better to at least get your tissue diagnosis or your biopsy obtained before you start treatment, unless you're going to go ahead and start them on multi-drug treatment, because you don't want to undertreat active TB with just one drug. So if you do have somebody who has a TB disease, and you are thinking that they are infected with drug susceptible TB, usually those decisions are made in conjunction with your Department of Health and or your infectious disease or pulmonary specialist who's probably been involved in their diagnosis. Most people will start with 4 drugs for an intense phase, and then as culture results are known, will pare down to 2 drugs. And especially if it's a pulmonary disease, you want to get your patient in direct observed therapy, and that is usually offered by your Department of Health. So getting your Department of Health engaged early on for those kinds of patients is really paramount so that they can be under direct observed therapy so that we know they're taking their medication and their risk for TB transmission goes down. There's a minimum of a 6-month regimen. Again, usually starts with 2 months of isoniazid, rifampin, PZA, and ethambutol for drug-susceptible regimens. Adverse effects of PZA and ethambutol can include, in addition to our hepatitis that we talked about, and we talked about our heme problems that we look at for rifampin, but it can also include optic neuritis, red-green blindness. So we send people for an exam at the beginning of therapy, gout, and as well as labile glucose levels with those medications. And you will do monthly AFB sputum testing, excuse me, for pulmonary disease because you want to make sure that their culture becomes negative. And in somebody who is being treated successfully, you expect a negative culture result at 2 months of treatment. And remember that a lot of times the AFBs will come back when you're monitoring someone still as positive, but it's really if the culture is negative that you're really looking for to make sure you have that you're being successful in your treatment. Now, of course, drug-resistant tuberculosis disease is a concern, and when should we suspect that or be concerned about it? If somebody has a previous episode of treatment of tuberculosis disease and now relapse with symptoms, patients whose AFBs do not become culture negative on treatment, or they seem to develop progressive symptoms on treatment, we should be concerned about that. And our real high, our areas, excuse me, with high prevalence of drug resistance include especially China and India. In the United States, about 50% of our drug-resistant tuberculosis are from patients from China and India, but you also see the other countries that are listed. Or if you have somebody who has an exposure to an individual with known or risk of drug resistance. And these patients certainly should be especially handled by the Department of Health if you are concerned about that, or one of your specialists. And there are second line drugs, levofloxacin, IV amikacin, etc., that can be used in addition with these kinds of patients. So those patients where you suspect drug resistance, definitely get the specialist involved. So let's talk a little bit about a few special situations. So as we pointed out, HIV positive patients are at high risk for TB disease and infection, and the risk increases as their CD4 declines. And often it's a difficulty making a diagnosis, which can be missed or delayed in our patients. And one of the things we should remember is that to have granuloma formation, you need to have T cells and CD4 cells, which are involved in forming granulomas. So often these patients, especially if they have progressive HIV or very severe immunosuppression, may actually have a negative chest x-ray and have active TB. So again, you have to really have a high index of suspicion in your HIV positive patients, especially if they are from high risk areas and they have very low CD4 cells. TB progresses more rapidly as their immunosuppression worsens. But when we treat TBI, when we treat TB infection and not active TB, it's as effective in the HIV positive as the HIV negative. But again, with the rifamycin-based regimens, we have to especially watch for drug interactions with their antivirals, and we also have to look out for hepatotoxicity. So when you're going to diagnose TB disease in the HIV infected patients. As I said, it's often missed or delayed. You want to check your sputum smears just as we said for the other patients. You do the smear, you do the culture, and especially you do your NAT test, okay, to make sure that you can capture the bacteria. But if available to your lab, there's another test called a urine lipo arabinomannan test, which I just call the LAM test. And this is one of those tests, if it's positive, it's helpful. But if it's negative, it does not rule out disease. And because people can have severe bacteremia, you also want to consider checking blood cultures for AFB in your HIV positive patients. And definitely, if you're going to treat TB in your HIV positive patients, you do want to make sure you have your ID doctors or your other specialists involved, because often patients will develop immune reconstitution syndrome where they can have fevers, seeming worsening of their TB disease. When you have the treatment of initiation of ART or your highly active antiretroviral therapy in patients who are on TB disease treatment. So again, I think the main take home for you would be HIV patients, especially those with severe immunosuppression. You want to have a high index of suspicion for TB disease, even if you don't get all of the classical signs and symptoms, and really work hard to make a diagnosis if it's a concern, and then get assistance with treatment.
Dr. Griffith-Howard, I just want to give you,
Yes.
we have about 8 minutes left.
Okay, I'm coming up to the end, so it should be good. Thank you. Thank you for the time check. Pregnant TBI and TBD patients, this is something that we often run into. So if possible, you want to test prior to pregnancy if possible, so that they can just complete their TBI treatment and you really don't have to worry about anything. As I said, we have the 4 months of rifampin, which can be used, but remember the concern about the nitrosamine now with rifampin, and some patients will be concerned about that. So if possible, the best of all worlds, test and treat for TBI infection and definitely TB disease before pregnancy. Recognizing that often as the gynecologist, because you do have a captive audience, will do their TB testing when they come to see them. Now your patient is pregnant, they have a positive TB test. Who do you want to treat? A recent contact of a patient with TB disease, if they have HIV infection, if they're immunosuppressed other than pregnancy, because pregnancy can be immunosuppressive in itself. Those are the patients who you want to treat. So most of the patients who come back with a positive test, you are not going to treat during pregnancy. Mantua or IGRA is acceptable, and there's some suggestion that both tests can be affected by pregnancy, but for our purposes, either is fine. If you have a positive test, you're definitely going to go ahead for a screen chest x-ray no matter what your gestational month is. And there really isn't a risk of vertical transmission of TB infection when we have patients who have negative chest x-rays. As I said, you're going to treat if a recent exposure or immunosuppression. Otherwise, usually you start 2 to 3 months after delivery. We have our same regimens that we talked about before. If they actually have TB disease, obviously you want to get them to a specialist. One other caveat that I like to remind people is, remember, rifampin is going to color secretions, including breast milk, that orangey color. And patients may be concerned about that. That is not a risk to the baby. And it's not that the baby's not going to get enough of the drug to be of concern, but you do want to warn your patients about the change in the color of secretions. Diabetes and TBI and TBD patients, you do have an increased rate of treatment failure or death if you have diabetes and tuberculosis disease. And there's also an increased risk of relapse if you have diabetes and tuberculosis disease. So one of the things that we should always do is that all patients who have a positive TB test for either TB infection and certainly